Let's talk about postural orthostatic tachycardia syndrome, or POTS. So POTS is a disorder of the autonomic nervous system. The symptoms are characterized by an intolerance for orthostasis, or standing up. It happens much more frequently in women than men, about a 5-to-1 ratio, and also in younger people as opposed to older people. So the most common person that would develop this disorder is a woman of childbearing age. It can also be associated with small fiber neuropathy, which is pretty unfortunate since that will also cause dysautonomia and worsen their symptoms. In order to understand POTS, we have to talk about the normal autonomic response to standing. So the blood will pool in the veins when you stand, and this will result in decreased pressure on the carotid sinus and aortic arch baroreceptors. That leads to an increased sympathetic response to compensate, which will increase heart rate and peripheral vasoconstriction. And also there will be a decrease in the parasympathetic response, leading to decreased vagal tone, meaning that the heart rate will increase. Various parts of the autonomic system can be affected by POTS, and you can have multiple parts affected as well. One thing to note is that the heart rate normally increases in the first 20 seconds of standing in healthy people, but this effect is prolonged in POTS. For clinical features, upon standing, someone will have lightheadedness, palpitations, or fading vision, presyncope, or occipital headache, and these symptoms will be better with sitting. These symptoms will also improve with walking, and this is because activation of the skeletal muscles will improve venous return. The symptoms can also worsen with hot weather or showering because this can cause vasodilation, and dehydration as well because you're intravascularly depleted. Patients will have a normal neurologic exam. In addition to the positional symptoms, there can also be non-positional symptoms, such as anxiety and fatigue, some mild cognitive dysfunction, non-restorative sleep, overactive bladder, as well as migraines and tension-type headaches. In order to make the diagnosis, there has to be symptoms of orthostatic intolerance. There may or may not be non-positional symptoms. And there has to be a documented sustained increase in heart rate greater than 30 beats per minute within 1 to 10 minutes of standing or tilt table testing. So generally you'll measure at 1 minute and then every minute or two afterwards. And if there is a sustained increase in heart rate greater than 30 beats per minute, then that is suggestive of POTS. Note that the tilt table is more sensitive and specific than a bedside exam, and so it's usually required in many cases in order to make the diagnosis. Adolescents will have different numbers, so for someone under 20 years old, it requires an increase in the heart rate of 40 or more beats per minute, and that's because adolescents have a more exaggerated tachycardia response to standing. One thing that is required is that there can be no orthostatic hypotension. So if there's a drop in blood pressure of 20/10 or more, then the diagnosis is more orthostatic hypotension rather than POTS. Some labs are typically sent to rule out other diseases such as electrolytes, a CBC, a thyroid function test, and an EKG. Treatment consists of increasing the intravascular volume by drinking about 3 liters of water a day and intaking 8 to 12 grams of salt. Physical exercise is extremely important, but patients cannot always tolerate exercise standing up, and so things such as swimming or recumbent bicycle may be more tolerable. It's advised to do this for 3 or more times a week for 30 minutes each. And in order to improve venous return, sometimes they can do exercises when standing up, such as tensing or crossing the legs, and that will improve venous return upon standing. Wearing compressive garments is also an option. Most patients, their symptoms can be managed without medications. However, if you need to use medications, then beta blockers can be used, such as propranolol and metoprolol. These will blunt the tachycardia response and help with symptoms. You can also use fludrocortisone, which expands intravascular volume by increasing renal sodium reabsorption. Midodrine is also used. It's an alpha-1 agonist that induces vasoconstriction and reduces blood pooling. Droxidopa can also be used, which is a prodrug for norepinephrine and causes vasoconstriction as well. The fludrocortisone, midodrine, and droxidopa all have a risk of worsening supine hypertension. So if someone also has hypertension, these medications may not be the best option. For prognosis, POTS usually improves over time, although there can be some flare-ups, and it has no effect on mortality.